Good evening, everyone. Good evening, everyone. Welcome. Welcome to our second Beyond the Headlines program of the year. I'm Renee Mannion. I'm your outreach chair, and I'm currently serving on the nominating committee. In the winter and spring each year, the nominating committee works hard to fill any openings we have in our leadership committee and also all the chair positions in our various committees. As you know, Impact100 Greater Milwaukee is a 100% volunteer-driven organization. And over our 7-year history, we've worked really hard to refine our organization chart to make sure that we have plenty of support in each area so that all positions are manageable and meaningful. As the saying goes, many hands make light work. There are positions available to fit into any types of work and personal schedules. And also we are very fortunate to have a membership filled with a wide variety of skill sets from accounting and financial services, event planning, public relations, marketing and communications, and education and professional development, just to name a few, which helps to create a very well-rounded team. Thank you to all of the members who have donated their time and energy across all of our committees to ensure that this organization runs extremely professionally. On each table, you'll find a half slip of paper listing all of the open positions that are still available for next year. Please take a moment to see if there is a role you might like to volunteer for, or if you know someone in our membership who might be a good fit for a position that you could refer to our nominating committee. Those serving on our nominating committee are here tonight, and we appreciate your help to match up the right people into the right roles. Thank you, and please consider joining our membership team. It takes a village. I have served on several different committees in my 6 years as a member of Impact100, and I will personally tell you that I have benefited far more from these experiences than any of the time and other things that I've donated in my efforts. In addition, I have gotten to know so many incredible members. We really do have a wonderful membership, and I've gotten to meet so many of our wonderful grantees and got to know all of them on a deeper level. So now I'd like to turn over the microphone to our Beyond the Headlines program chair, Jill Boyle. And thank you, Jill, for your hard work on putting this really impactful event together for us this evening. Thank you.
Thanks, Renee. As she mentioned, I'm Jill Boyle, and I'm the chair for the Beyond the Headlines event this year. We've had some really good feedback from our members on really wanting to dig in on some of the issues that we see as we're reviewing grant applications and things like that. And so the idea behind these really are truly beyond the headlines. What are we seeing in the news? What are we hearing a lot about in Southeast Wisconsin? And what can we learn about that issue to be better philanthropists and more educated as we're reviewing grant applications and things like that? So the opioid epidemic, that is a tough word to say, and I'm probably going to stumble a few times tonight. So obviously not just a Southeast Wisconsin issue, a national concern is really impacting so many millions of Americans. And again, Milwaukee, no different. It's a big deal here in Southeast Wisconsin. So we wanted to bring together a panel of experts that really is going to give us some different perspectives on, what they see in their daily lives and their jobs. And, we understand that everyone here is probably coming at this from a different angle. You might really not know a whole lot about this yet. You might have some personal experiences with it. So we're going to start really with the basics. I think it's a good place to start. We all need to sort of understand this how we got here question. It's probably not that easily answered, but we can at least learn some of the background from the experts we have on our panel. So the way this is going to work tonight, our 4 panelists each are going to talk for approximately 10 minutes, short, long, whatever they're feeling, at the beginning, just to sort of give us a background on, what angle they bring, what expertise they have here. So each of them will go individually, and then I'm going to sort of ask them to, comment on each other's, make some notes, and sort of get a dialogue here again of just sharing their experiences with us. And then I have some questions I can ask. We will have time for a Q&A from the audience, so if you do think of something, jot it down, feel free. We are going to pass some mics around later that you can, ask any of those questions that come up as you're listening to our panelists. So on our panel tonight, in order here, as they will be speaking, we have Jennifer Smith, who's the clinical supervisor of NAMI Southeast Wisconsin, who was a grant recipient from our organization in the past. We have Terri Ellzey, the director of clinical services at Mental Health of Wisconsin. We have Beth Ritter, who is the mother of a son who suffered from substance use disorder. We have Danielle Long, the Opioid Initiative Advisor for Wisconsin Department of Justice. So please help me welcome our panelists and thank them. And then I'm going to turn it over to Jennifer to get us started, give us a little intro on your background.
Sure. Is this on automatically?
It is not.
Does it need to be on? Got it. Oh, no. Apologize, did not think of that.
Was it working? Okay.
Oh,
There it is.
it sure is. Okay. Nobody ever told me I needed to talk louder. Okay. So, my name is Dr. Jennifer Smith, and I am a licensed professional counselor with a doctorate in clinical psychology. I obtained my master's degree in clinical psychology from the Wisconsin School of Professional Psychology in 2009. WSPP is a local program that focuses on providing education from a clinical perspective versus a research perspective. And so that graduates really go out into the field being able to be clinicians versus focusing on research. That's what a traditional PhD program does. I obtained my doctorate from WSPP in 2017. My first experience working with individuals with substance use disorders was during a practicum placement from 2008 to 2010. I was placed at Maida House, which is an outpatient and residential facility in Milwaukee County that helps women suffering from substance use disorders get treatment, maintain their relationship with their families, especially their children. I provided group therapy during that time, focused on stress and anger management. I also did individual therapy to address more personalized needs, and did psychological and neuropsychological evaluations that would help us know what exactly did they have for mental health diagnosis and what kind of treatment recommendations would be most beneficial to them during their recovery. After I graduated, I went on to work at an outpatient clinic called the Bridge Health Clinics and Research Centers. Our initial focus was just on general mental health treatment. Shortly after I started there in 2014, we obtained a contract with the Department of Corrections Division of Community Corrections, meaning we were providing support to individuals who were on probation, parole, extended supervision. They were no longer incarcerated, they were released into the community, and they had to follow up with a probation agent to make sure that they were still following the laws and rules of their initial sentencing. We started to provide group therapy primarily with them to address substance use disorder. That was all substances, from alcohol to opioids and everything in between. After that time, I also did individual therapy during that time as well, for individuals that it was apparent that group therapy would be less beneficial for them. But after that time, I moved on to working at where I currently work, which is Ann Hebner and Associates in Brookfield. I do a little bit less substance use treatment now, but I still do maintain connections with some of the probation officers that I've worked with. They still send me referrals. I still see people seeking substance use treatment on their own accord that just reach out to me and say, hey, you have this experience. Can you help me with this? Okay. As far as my work with NAMI, I started to volunteer for them in 2008. I became their clinical supervisor in 2016. I also started to co-facilitate a survivors of suicide support group in 2013. Along the time since 2013 to now, many of the individuals that have lost their lives to suicide were overdoses. And so that, certainly plays a part into providing support for the loved ones that are now trying to grieve the loss of their child or their loss of their family member, whoever it might be. So NAMI is a grassroots organization that started in Dane County in 1979 with the goal of providing support, education, and advocacy for individuals with mental health conditions. It is run by individuals who, largely the individuals that work for us and volunteer for us are either individuals who have lived experience of a family member with a mental health condition, or they themselves have they themselves have a mental health condition. While we don't provide services solely specifically to substance use disorder, we do see a lot of individuals that reach out to us that have what we call dual diagnosis, which is a mental health condition and a substance use disorder. What we see with mental health is that people living with mental health are at a higher risk of developing a substance use disorder in their attempt to cope with the negative emotions that they have, the stressors that they face. Substance use, alcohol, drugs of any kind, including opioids, it's an unhealthy coping skill, but it's a coping skill. It is very effective. You take this thing, it makes you feel better for a period of time, right? Coping skills are designed to make us feel better for a period of time. The reason why substances are an unhealthy coping skill is because the consequences far outweigh the pros that you get from that substance. And so that's one of the things we have to contend with providing treatment, is helping people learn there are other healthy coping skills while not necessarily as effective. And I say that in quotes because they are as effective if you use them long term. The quick fix is what we get from the substance use. Some statistics right now, we find that 1 in 5 adults is suffering from a mental health condition. About 1 in 20 adults is suffering from dual diagnosis, substance use and mental health condition. And so there's a lot of individuals that are needing support. And finding the best type of support for them is sometimes the challenge. I'm going to go a little geeky and talk about why it's more of a challenge, I guess, geeky.
Love it.
There's this debate of substance use being a choice, whereas in the community, it's a disease of choice, meaning somebody makes the choice to use a substance, okay? There's a choice piece that comes into it. It's not always a choice that you have full information from, like your doctor gives you a medication, says, I think you need this, then you take it not knowing. You're not going to argue your doctor. It's still a choice on some level. It becomes a disease over time because of the changes that happen in our brain. There are two primary things that happen. Our dopamine, which tells us what something feels pleasurable, and our glutamate, which is our memory chemicals in our brain, they start to change. And so you take a substance, and dopamine increases its threshold of what it expects. And glutamate says, so this thing is important according to dopamine, and glutamate says, I'll remember that, and I'll make sure you get it the next time you need it. So it's not as easy as you take a substance and nothing happens. Your brain is doing a lot of work that you don't realize that makes it that much more likely that you're going to take a substance again. It doesn't necessarily guarantee you're going to, but it makes it more likely that you're going to. And you're going to reach for that substance in times of stress, in times of emotional pain, because it works so well, okay? See what else I wanted to add on to. Going into what, kind of the best approach to treatment is really looking at the person from a whole, okay? Understanding that brain changes are happening, which also makes us interpret things inaccurately. some people who are seeking treatment for substance use disorder are saying, well, I'm experiencing physical pain. I'm experiencing physical pain. Emotional pain can also present as physical pain. And so really to treat somebody who has substance use disorder or dual diagnosis is to look at the person in terms of what's their mental health, what's their substance use, what's their physical ailments, because we're also contending with, I do have legitimate physical pain and I need to take these medications, but how do I not take them in a way that it's abusive? There's lots of ways that we approach treatment, you know, starting with we have to keep the person's life safe, and so detox, sending them to detox to make sure that the substance is out of their system in a healthy way that they can start to address treatment in a more helpful way with inpatient or residential to outpatient. There's also medications that are used to help with opioid treatment that can be helpful along the way depending on the specific individual. I know I went a little bit all over the place, or I felt like I did.
It's okay.
Touched on most of what I wanted to touch on, so.
All right, thanks. Terri, you want to take it over? Good.
Hi, everyone, and my name is Terri Ellzey, and I am a clinical substance abuse counselor. I am a licensed professional counselor, and then I'm a clinical supervisor in training. And so my professional experience goes back to 1995, which I shouldn't be saying that out loud. And so I started as a human service professional pretty much. I was just sitting here thinking like my life was like the case of Curious Benjamin Button. I started backwards. So I worked before I actually went to school. And so working in the field actually made me go to school so I can learn more about just human behavior and substance use, mental health, and all that kind of stuff, because I am a curious person. And so over the years, the one position that got me into addiction studies or work was when I worked for Wisconsin Community Services, which is used to be known as Wisconsin Correctional Services. And so it's a organization in the city of Milwaukee. I was primarily started off working with state and federal offenders, usually those coming out of the institution from long sentences longer than 10 years. And so at the time, there was a period of time when they were actually in the workforce promoting people to get their substance abuse licensing, because it's what the Department of Corrections and the United States Probation wanted, and the Bureau of Corrections as well. And so I said, oh, what the heck, might as well add that to my plate. And so from there, I have been pretty much working in the field now for about 27 years as far as with substance use and mental health. And so opioids was actually very new to me as of like 2010, because before that, most of the clients that I worked with had alcohol and crack or cocaine dependency issues, and the opioid people were like one maybe out of 35 clients that we might have been serving at that time. And then interestingly, by 2013, I seen a drastic flip out of nowhere. It just became like mostly, I would say probably about 2012, in a residential facility that I was working with at the time, I'd seen a very big increase real quickly of the opioid epidemic happening right in our face before we even knew what was going on. And so from that point on, it's just been a lot of information over these past couple of years, learning new things about opioid addiction, including historically, this is not the first time or the second time there's been a crisis. And so I'm not a doctorate in PsyD as she is, because I don't want to do the brain stuff. I'm just totally like not good in that area. But I am a doctoral student for leadership for change, as it's my goal to like be a leader in change as to a lot of the different things that are going on in our communities, to kind of help the process of people forming different perspectives about what is going on and what causes these issues. So, to that point. So my first is a disclaimer, and the disclaimer is that I don't know if this is, oh, there we go, hey. So the disclaimer is just to let you know that some of the things in this presentation may seem offensive, but I know we're all mature adults in here, and so these are just things that I see on a regular day, and I want it to be very authentic in what I say so that people understand what to look for when we're talking about anti-stigma reduction, not just for opioid addiction, but across all addictions. So what is stigma? So, is it Jennifer? Mm-hmm. So as Jennifer was stating about the different things that goes on with a person who lives with substance abuse, I just wanted to add that that same part of the brain that holds the addiction for opioids also is the one for them chocolate cake and brownies on the table too.
Our pleasure center, all pleasure.
All pleasure. Thank you.
I always give the example, and really quick, sorry to interrupt. You go to a gumball machine and you put a quarter in, and you get a gumball, and you're like, great, I got a gumball. You go to a gumball machine, you put quarter in, and you get 2 gumballs. Your pleasure center has changed because what you got was not what you expected. It's any pleasure.
Exactly. Potawatomi, for those of you who are guilty.
There you go.
There she go. So again, the stigma describes the powerful negative perceptions commonly associated with substance abuse, addiction, and deviant behaviors. So again, going back in history, addiction, even starting with Bill W., who is the founder of AA, Alcohol Anonymous, will tell you that stigma goes all the way back to that period of time as a deviant behavior. So people who actually had substance abuse issues used to be locked up in prison, jails, or asylums. So just to kind of give you an idea of what that used to look like before it became medical model. Stigma has the potential to negatively affect a person's self-esteem, damage relationships with loved ones, and prevent those living with addictions from accessing treatment. So if a person is feeling already bad about their situation, it is hard to ask for help. When I do assessments with clients coming into our program, I will always ask, are you okay with asking for help? Because it could be very hard, because in that addiction, you might have made a lot of doors close on you. So at some point when you really want help, it may be a little bit difficult. Stigma is a public health issue as it contributes to high rates of death, incarceration, and mental health concerns. And we know that a lot of the mass incarceration that happened over the past 20-something years had a lot to do with crack cocaine or cocaine, crack versus cocaine, which there was a lot of legalities. I don't want to get into that right now because I don't have time. But again, it's good that they're starting to look at it from a treatment model versus corrections, and we'll talk a little bit more about that later. Stigma is a major cause of discrimination and exclusion and contributes to the abuse of human rights. Layman's terms, stigma is stereotyping, it's discriminating, labeling, and being judgmental. So one of the things that you'll be surprised to learn is stigma is actually, it does exist within certain drug cultures, right? And just to kind of give a little, example of that, so for opioid users, I've actually heard people in treatment will say, well, I only use pills. I never went beyond using, pills, and I got addicted because my doctor prescribed me way more pills than I needed. And by the way, doctors did. They used to, like, what do I need 180 Percocets for, right? Versus then you have the ones who will say, okay, I don't use heroin, but I use the pills, which at the end of the day, it may take a little longer for the pills to build up in your system to have withdrawal, but at the end of the day, you're all going to end up in the same place, right? And then you have those who may use the drug intravenously, like I snort or smoke it, but I don't shoot up. Okay, so you'll be surprised that even within the culture of drug use, people still stigmatize each other. This is the same experience that went on with crack versus cocaine. People who would use powder cocaine, it was interesting how back then it was known as an elitist drug. So people in Hollywood and the go-to with the powder lines and $100 bill roll-ups, I don't know nothing about that, but you know. And then versus the crack cocaine was seen as very urban and discriminatory as to the race and the culture of that going on. And then alcohol, I don't know how many of you guys do this, and you don't have to raise your hand, but there are people who actually have this thing about top shelf versus bottom shelf, right? Like, I only drink Cavassier and Dom Perignon versus malt liquor, right? And so the alcohol versus the drug users, okay? If you ever been to an AA meeting, it is so divided. Like, there is so much shaming, like, I only drink, I don't use drugs. And that is also very prominent in a lot of the addiction treatment centers where people who drink alcohol will separate themselves from those who use drugs. And alcohol actually is probably one of the worst out of all of it.
You're a slide ahead, actually, so you don't need to.
Oh, okay.
Perfect.
So how substance use has been tied to racism. So this is always a controversial conversation to have, but one that I love so much to have. And so as I would comfortably say, is that, you know, there has been some discrepancies in how opioid addiction is looked at upon versus how crack cocaine was looked at in the 90s, right? Because as everybody pretty much knows at one point in time or another, an issue does not reign precedent until it knocks on your own door, right? And that could be anything. It could be breast cancer, it can be colon cancer, heart disease, anything that human beings may become vulnerable to. We do not show interest in it until it knocks on our door. And so opioid, you know, the word around town, and I've had my own comments about it too, is that it did not become a medical model or a brain disease until the population changed, okay? And that's just having to be honest about that. And so crack cocaine stigma was made criminalized, largest population to be incarcerated, second to the Reconstruction era for mass incarceration of black men. So if you know anything about history and the beginning, right after the Reconstruction era, when black men were arrested just for vagrancy and not being employed or anything, the crack epidemic had the second largest mass incarceration in history. Opioid dens in America started in the 1800s. It was followed with the immigration of the Chinese who came to do the railroads in the Bay Area, in Seattle and stuff like that, which, by the way, again, I'm a historic junkie, so actually, until the opioid epidemic came about, Seattle, San Francisco, and parts of Canada still had a lot of issues with heroin use all this time. Like it never, like from white China to black tar heroin, they always had a problem with it. And actually, Canada was one of the earlier places to start harm reduction with giving out needles and stuff. So a lot of the research that has been done has been centered around what Canada has done over the years. The opioid epidemic of the 21st century favored white patients to be treated with pain medication, whereas the age-old myth portrayed blacks as being susceptible to pain, and reasons why whites were overprescribed pain medication, stigmatizing blacks' need for pain medication as suspicious for illegal use and distribution, okay? And again, there's another historical issue of blacks having less pain tolerance, okay? And that's a historical thing too. And that still goes on to this very day, not just from the past, but also to the present. I can go on for a minute about that as well, but I'm not. And then the opioid epidemic, unlike the crack cocaine epidemic, focused on treatment of the substance use disorder versus criminalizing individuals and their addictions. Cocaine dependence is not prioritized as the same as opioid misusers. And so I don't want to go into the details of this, but even now, as when you like call for AODA treatment services, right now there is a priority if you are an opioid user over others. The only other intoxicant that will kind of be favored is alcohol, because alcohol, if you are a serious chronic alcohol user, that's one of the things you can die from if you're in withdrawal. So how anti-stigmatization supports recovery. So again, keeping in mind that criminality versus medical model, mass incarceration versus treatment, that is what we need. We've been needed it, but now that everybody's on board, let's continue the effort to help people get well, okay? Yes, it starts off as recreational usually. Yes, it may start off because I had a soccer ball injury. Yes, it may start off because I fell at work. But sometimes it exacerbates over time, and whatever the reasons are, we still have to be open-minded to help people, because some people will sit up there and be stigmatizing somebody with an addiction and be smoking cigarettes, eating their third piece of cake, or they just lost their house at Potawatomi. And so we have to really start looking at these things in a way that we're not looking at them as they're not human beings, right? Urgency to take notice is the language, addicted. So like back in the 70s, you had the term junkie, right? Instead of saying living with substance use disorder. And honestly, even as a provider, I have to train myself to even speak in anti-stigma language, because again, I started back in the 90s when everything was good to say crackhead or junkie or drug addict, you know, and I have to really train myself. And one of the, I'm not gonna say his name, but one of our medical doctors, I was like, oh my God, you are just making my bells ring in my head. As, you know, he's like, I don't care, you know, go back, way back to serving. But it's like listening to that actually helped me even work harder to make sure I don't do that. And then the investment in intervention and prevention. So again, learning more about harm reduction. What is harm reduction? Harm reduction is different across different substances. Narcan is what most people are now using to save a life, right? So now they're starting to have stationaries that are out here in the community so that if you see somebody who may be overdosing, you can save their lives by giving them a shot of Narcan. Now keep in mind, from what I've experienced over the years, most of the people who overdose say that was the best high of their life. Keep that in mind. Reducing barriers to treatment, availability, and priorities. So real quick, anti-stigma language, again, we talked a little bit about it, and this just goes back to like saying, you know, if you change, and this is across not just AODA stuff, alcohol and drug and addiction, this is not only for that, but changing the stigma of language, period, right? And I can go on in that conversation too, but you know, when we look at persons living with an addiction versus suffering or battling addiction, or if we look at persons arrested for drug violations or reentry consumer versus drug offender, and I think I like the one that that says had a setback instead of relapse, right? This person just had a setback, right? We all have setbacks in some form or fashion, so keeping that in mind.
Go back.
Oh. Oh, there you go. So, yes, thank you. So, and I know I got a few minutes, that's why I went forward. So, yeah, saying this, that, or not that, but like, again, maintain recovery, staying clean, positive drug screen, dirty drug screen. So instead of saying something is like a dirty drug screen, we want to keep a positive drug screen. So again, if you change the language, you'll change the way you look at the person who has an addiction. And that's what's important. And I have to move forward, I apologize.
You'll be able to see the materials as a follow-up to the day.
So real quick, and this might get a little bit testy, how privilege harms substance abusers. Race and socioeconomic factors play a role in where the person goes, treatment or jail. Facts. Types of treatment services to include the level of professional services by highly qualified and trained addiction professionals. So if I make maybe 6 figures a year, my child is having an addiction, even though he might go to this recovery spot, recovery camp for 4, 5, 6 times, draining our income, that's going to be a lot better than probably going to some other, like, more marginalized in the community where more drugs are sold type of services. So we have to take into consideration NIMBY, not in my backyard. Not saying you have to open up your backyard to treatment providers and stuff, but still kind of think about how most of the services are concentrated in areas that make their situations worse than better. Also, the types of treatment services to include less consequences or accountability when compared to other racial socioeconomic groups, given more chances based on family, economic status, or race. So again, the way the interactions are done far different for white clients than they are for black clients or brown clients. And then likely to overdose as a result of enabling and codependence. As a provider, I asked a couple of my clients I just said, do you think a lot of your friends die because they're white? And they kind of were like, huh? I said, well, if they would have had like an intervention, like jail or something, you think they'll still be here? And they was like, I never thought about it, but yeah, And so not saying you guys, if you have children or nieces or nephews or anybody that say go to jail, but I know that a couple of clients I've met over the years have said, I was arrested, which was a rescue, because it stopped the behavior automatically. And it's not saying that they still can't acquire substances while they're incarcerated, but it does kind of stop the behavior so they're not just still using, because we know how deadly it is, especially now with fentanyl out here in the world. So the last part, as I get ready to wrap up for time, is, again, barriers to treatment. So the barriers right now to treatment are insurance, right? Not all insurance companies provide a plethora of this type of resources people can use, and all people are not privileged to have certain insurances that cover a lot of things, including co-pays for like medication assisted treatment, Suboxone or methadone and stuff like that. And then also, this again, barriers to treatment is stigma. I'm embarrassed to go knock, you're not embarrassed to go knock on the drug dealer's door, but you're embarrassed to go knock on help door. But then that's part of the distortion of addiction. And then lack of information, having people here to have us here to talk about this and learn about this is like, you guys give yourself a hand for this, because this is important stuff. And so I applaud you for taking the time to learn about what this looks like. And then licensing, training, and credentialing is hard work, right? And we're not paid like we attend school, right? So you need a master's degree for most part, and the licenses, usually the exams cost about $275. The licenses cost about $150 every 2 years. And then the ongoing training that if you can't catch them for free, they're about $30 to $150 a pop, depending. And so it is an expensive profession to be in with little kickback. And so I know they wanted to know something about the SCPMH, but I'm not going to go into that because that's kind of like something different. But I want to thank you for my time, and I'm sure we'll have questions later.
Thank you, Terri. All right, Beth, you're up.
I'm up. Okay. Hi, my name is Beth Ritter, and I'm going to start out by saying this is my first time speaking in front of people to tell my son's story. Sorry. Didn't know that was going to happen. So I'm going to be telling my son's story with substance use disorder. He started out 12 to 13 years ago with an injury that sent him to the hospital. He had a pier fall on his shoulder, and it hurt his shoulder and his back, and took him to the hospital, and they ended up prescribing him opioids and muscle relaxers. they kept prescribing him muscle relaxers and the opioids for quite a long time without saying you shouldn't be taking these for so long. You can become addicted to them. And I don't know if it was as big back then as it is now of an ordeal or not, if they just weren't seeing it at that point in time. But they didn't give me that warning, and I should have known, but, you know, you take what your doctor says to be truth. You know, doctor says you're in pain, this is gonna help you, you know, we'll get you through this. So, he went back and forth between his ortho and his regular physician, and they would each keep prescribing him, and this went on, I would say a couple of years, where he just was on constant pain meds, constant muscle relaxers, and then he started to overdose on them. He tried to commit suicide with these drugs that he had been given by his doctor to help him. He was trying to use to hurt himself, and that in itself was very painful. And you know, we were very lucky that he had called a friend and that we got to him in time, and were able to save his life at that moment. He did end up staying at Rogers for a short period of time, which he was also diagnosed with bipolar. Sorry, I can't see what I wrote, so so I'm just going by what I'm remembering here. Before this, he was your normal teenager. He was into cars, he was into motorcycles, he played his bass guitar in the church band. He rebelled a little bit, but you know, what teenager doesn't? And he had brothers, and he has brothers, and they fought, but they were best of friends, worst of enemies, you know, so they would go back and forth. And then after becoming addicted to the opioids, that all changed. That dynamic between the brothers all changed just because of the behavior that Blake was displaying. Let's see here. After a while of being on these pain meds, once he started overdosing on them, they tried to wean him off the opioids and get him back onto something that wasn't addicting. They tried, you know, I know gabapentin was one of them, and there were a couple other drugs that they tried to use, and this went on for probably a couple years that they would try different things, and he would still try to commit suicide with using these drugs. And it all started with the opioids. I can't say for sure when he became addicted, but I do remember at one point a change where he would start asking for $40 here, $40 there, and he would say it was for different things, and he obviously wasn't working because he was in pain, and you know, he couldn't work. And at first we would give into the giving him the money for whether it was for diapers or he needed, you know, body wash and shampoo and, you know, daily living things and things like that, or food or whatever, because he was homeless for a while as well. That was about when he started using other illegal drugs. I know for sure cocaine was one of them at that point, but I'm not sure what else he was using. I didn't realize how quickly you could become addicted to anything, yet alone something that your doctor prescribed to you. I wasn't aware at that time how fast the snowball can start and how fast it just continues. Let's see. There were many reasons why he kept using. So over the next couple years with his usage, his grandmother, who is very close to passed, he had his first child, which was very stressful on him because he was addicted and didn't know how to handle a child or a girlfriend to help take care of that child or anything like that. So it was very stressful on him that way. And his vice was the drugs. His uncle, who was more like a father to him, passed as well. And then the mother of his first child decided to take that child to live in Tennessee where he could no longer see her. And that was all because of the drug use, because he wasn't willing at that time to go and take the steps that he needed to get clean and get sober. We figured out that over several years, his aunt gave him over $40,000 to support his habit. And she continued to do so even after we asked her to stop, and knowing what the habit was for, because at this point it had turned into a heroin addiction. And she just kept saying, well, he needs it for diapers, he needs it for wipes, he needs it, no, for, you know, if he needs it for food, I will buy him food and put it in front of him. I will go buy those diapers, I will go buy those wipes, I will give them to him. But you can't keep giving him the money. And it was probably a lot more than what she even told us, because I know that she tended to keep things under the wire. But that was a lot of her 401k. She almost ruined herself trying to support my son's drug habit, which is a very hard pill to swallow, knowing that I wasn't willing to do it, but yet he found somebody else that was, and was kind of blocking our chance to get him the help that he needed, because I think that if she wouldn't have kept doing that, we would have had a better chance of getting him in and getting him help. Then his dad passed away, another uncle passed away, and he had a child with the woman who had got him addicted to IV heroin. The baby was born addicted to heroin and cocaine, so she was in the NICU for many months, and it was heartbreaking to watch because neither one of them were there for her. They would go up to the hospital for maybe 15, 20 minutes a day to see her. And then all the rest of the time, all they cared about was finding that next high, you know. And so when it came time to bring her home, it was very worrisome that we didn't know how that was going to come across, because they obviously weren't in a place to take care of a child. His grandfather also passed. And all of these things that he went through within a matter of years was just enough of a punch in the gut for him to make him want to keep using and not to have the strength to say, okay, I'm done with this, let's do this. He was seen in many different facilities all across the country, but he would either not finish the program or he would get out and immediately go and use again. Mostly, and I'm not blaming this girl, but he needed to separate himself from this girl that he had the baby with because together they were toxic. And that's all they did was get high and look for that next high. So if we could have managed to get that apart, you know, maybe he would had a better chance. On March 18th of 2021, he overdosed for the last time. I received the call the night of his big brother's wedding rehearsal for the wedding the next day, and he had been laying there for over 20 hours without anybody finding him. And on March 31st, or I'm sorry, on March 30th of 2021, he lost his battle to a fentanyl overdose. Sorry. I do not think that this is the end of his journey, because I'm hoping, well, hopefully next time I won't cry. But I'm hoping me telling his story to people and letting people know that it's okay to seek help for those that are going through these things. It's okay to seek help for yourself. I should have sought help for myself while we were going through all these things, because that would have helped me tremendously. I am now getting treatment for myself, and it's okay to get treatment. And it's okay to have the feelings that I'm feeling, and people need to know that it's okay to be struggling if that's the case, if that's what you're going through, and it's okay to let people know that you need that help. It's much, much tougher if you're going it alone and don't have the resources behind you to back you up and have a support system. So if anybody here is going through this, please just know one thing: it's okay to get help. And I hope that you do reach out for help, whether it be for you, for someone else in your family, or a friend, a neighbor, or anything like that. I just wish that can happen for you as well. Thank you. That's all I have to say today.
Thank you, Beth. It's awesome. Danielle, you're up.
Thank you. Can you hear me? Okay. Can you see me? I'm 5 feet tall, so when I stand behind a podium, I often have to ask that question. So I was busy handling drug take-back day today, so I asked if I could go last. I'm really regretting that now, after going after these 3 phenomenal women. I'm batting cleanup. So I have a lot to share. I'm going to try and squeeze an hour-long presentation into 10 minutes, so I'm going to speak really quickly. I am the Drug Initiatives Advisor to the Attorney General at the Wisconsin Department of Justice, so I handle policy, programming, and legislation. Like Terry, I started in 1995, but I started working in the criminal justice system at the District Attorney's Office. So I started at Marquette, and then I went over there to the courthouse, and now I'm here. So I worked in the DA's office on sensitive crimes and domestic violence cases for quite a long time, and then moved over to when I realized that direct service was not my cup of tea, especially in sensitive crimes. I couldn't handle it anymore, quite honestly, and so I went into policy and worked in the Supreme Court on policy related to restraining orders. And so I went over to the Department of Justice. It was former Attorney General Brad Schimmel wanted to get back into the drug take-back program, and they needed somebody to figure out how we were going to do that, and somehow they tagged me. And so I was like, okay, so that's how I started with this. And I'm also, I know Renee Mannion from the Your Choice to Live board, so that's how I got here today. So it was, fentanyl was mentioned quite a bit tonight, and fentanyl is something that scares me as the mother of 2 teenagers, and knowing what I know, it's terrifying, and I want you all to leave here tonight having a grasp and understanding of fentanyl. So I'm just sharing some data from the Milwaukee County Medical Examiner's Office. These are non-natural deaths related to fentanyl. And I know it's hard to see. You all are going to be able to access my slides, so you'll be able to take this with you. But you can see that sharp incline, and that's what we're seeing in Milwaukee County. If anybody can see this, I'm going to give you my car, because this is really, really small. But just so you understand, for the fentanyl alone or in combination deaths, in 2012, there were 5 in Milwaukee County. In 2021, there were 508. I don't do math, it embarrasses everybody if I try to in public, but, and we're not stopping. And so this is a problem that we're seeing. And again, these are really hard to see, but these spikes are fentanyl alone or in combination. I believe we talked about polysubstance use. We are seeing a lot of drugs used together, especially what I've heard often called the Holy Trinity. So you'll have opioids, gabapentin, benzos, and so it's the ups and the downs. And so we're seeing fatalities as a result of that. So anyone here heard of the Dose of Reality campaign? Other than Renee. Thank you. Okay, so the Dose of Reality campaign, and that's the website, doseofrealitywi.gov, was started with the Department of Justice many years ago, and it was really trying to capture what was happening with the opioid epidemic. I've been working very closely with the Department of Health Services over the last year to update this campaign, and as Terry talked about a lot, really trying to get our messaging out in an anti-stigma way. And we really want to encourage you to go look at this website because not only are we trying to work on primary drug prevention, but we are just really trying to focus on those who are struggling with substance use disorder and do it in a way that helps them seek treatment, and also their family members, their friends, their loved ones, really try and get away from stigma as much as we possibly can. So the Dose of Reality, we talk about opioids. We give a lot of facts, a lot of information. Has anyone heard of the book Dreamland by Sam Quinones? Okay, we got one. That is a phenomenal book, and it talks about the intersection of black tar heroin and the opioid epidemic starting up at the same time, and it's a fascinating explanation of how we got here. So just really, I'm not going to go through our whole website, obviously, because that would be painful for everybody involved, but I really want to encourage you to visit it. We talk a lot about what to do, and we talk about small talks. Everybody says, talk to your kids, talk to your kids, talk to your kids. Everybody says, about what? What am I supposed to say to my kids? What am I supposed to say to my parents who are struggling with substance use disorder? And so our campaign really gives some good information about how to have those conversations, when to have those conversations. Anybody who has kids know you have those conversations in the car when you're driving, right? I learned that when I have 2 teenagers. So just a lot of really good tips on how to have these conversations and what to say. I'm the vice chair of the state advisory team for the overdose fatality reviews. I like to, like Beth talked about, I look at these overdose fatality reviews as a legacy of someone that we have lost that we can all learn from. And so out of those come recommendations for change. And so, for example, we recently had 2 fentanyl overdoses in dorms at UW-Milwaukee. And out of that, we talked about the fact that we need Narcan in the dorms for UW, all colleges, but starting with UW. You have AEDs in the dorms, you should have Narcan as well. So this is a very interesting process where we are making sure that we are learning from the lives that have been lost. So the Prescription Drug Monitoring Program, or the PDMP, anyone familiar with this? Oh, we got two, three. So it was talked about, 180 pills for, whatever that was, your wisdom teeth, right? Because you'd have dentists, like, here's your 180 Percocets. And so the Prescription Drug Monitoring Program is a national model. And so what you may or may not realize is if you go to the doctor and they end up prescribing something for you, they have to enter this into this Prescription Drug Monitoring Program. And so it tracks, and we've done a lot to educate doctors and dentists and whatnot to say, please don't send somebody home with 2,000 oxy. They don't need it. So this is a good way for them to track if someone is getting prescriptions from different places. It helps also track doctors, because I work closely with the DEA, and they track doctors who are prescribing unnecessarily. Narcan, we've talked a lot about. I hope that this is one of your big takeaways tonight, because I want to get as much Narcan in the hands of as many people as possible. Although, Terri, you taught me tonight, I didn't know that was the greatest high. So we're working really closely with public health departments to get Narcan throughout communities. And we just released a grant for law enforcement, because we want our law enforcement to have it as well, because in our surveys we've realized that they are often the first to the scene. So it's non-addictive, and it reverses the opioid. We typically use the nasal form. It's easy to use. Anybody can use it. It's not going to be detrimental to someone's health. So on our website, we also have where you can get Narcan, because a lot of people don't know where you can get it. You can go into Walgreens, you can get it. You can ask your doctor to get it. We've been working on one of the recommendations of co-prescribing, asking doctors, if you're going to prescribe an opioid, also prescribe Narcan. So that's one of the things that we're working on. So Drug Take Back Day. Who's familiar with Drug Take Back Day? Oh, yay. Okay. So I coordinate this program. I just spent the whole day at the Waukesha Expo bringing all the drugs that have been collected throughout the state to one spot. So I've been working on this for a couple of years now. Do I have any real estate agents in the room? No? I thought that was a slam dunk. Okay. So in our public awareness campaigns, we're trying to target certain groups, and real estate agents are one of them, because you go into an open house, right? You put your house on the market. People come in your house, and do you clean out your medicine cabinet before you have 30 strangers coming through your house? So we've been working with real estate agents to say, talk with your clients and make sure if they have a medicine cabinet filled with painkillers, to clean that out so we can secure them, because people will look for drugs in any way that they can, and that's we found to be an easy place to get them. So again, on the website, Drug Take Back Day is 2 Saturdays a year. So the last Saturday in October, the last Saturday in April. So we just had it this past weekend. But as I like to say, Drug Take Back Day is every day, because we have over 500 permanent drug drop boxes around the state. So law enforcement agencies, clinics, hospitals, pharmacies, you can find these on our website. So please, if you're holding on to old medications, if you have a loved one that you lost and you're like, I've got all these drugs in the house, I got to get rid of them, please do, because we know that when people get their hands on them, it ends up that the addiction can happen as a result of that kind of access. So it's important we clean out our medicine cabinets. So just information that you'll find in the materials about what you can bring and what you can't bring to Drug Take Back Day. And this is just a cool infographic to show, actually, this is now outdated, because we've collected and disposed of now over 800,000 pounds of drugs in Wisconsin since 2015. So this is what it looks like when we collect them, and we come together and we put them on pallets, and we put them on a semi-truck, and we send them to an incinerator. And so I'm not competitive. That's not true. I am very competitive. But if you look at the map, these are the national DEA figures. And if you look at Wisconsin, in April of 2021, we were #1 in the country for drug take back. We usually compete with, thank you, Renee. We usually compete with Texas and California, which is pretty amazing when you think about the population of Wisconsin versus the population of Texas and California. And so I like to compete with them and see what happens. We always have the highest number of law enforcement agencies participating, which I love. They are our partners in this. They love feeling like it's an action step. And I think that's something for all of us when we sit here and we feel helpless and we hear these stories and we hear about what Beth endured in her life, and we say, what are our action steps? What can we do? You can start by cleaning out your medicine cabinets. So I was asked to talk about the opioid settlement funds, which that whole Wordle thing that's out there on Facebook and whatnot, I still have no idea. I don't understand it for anything. That's kind of the same about how I feel about the opioid settlement funds right now, because it's incredibly confusing. I work for the Attorney General, Josh Call. He filed these opioid lawsuits. We are hoping that they will settle soon. They've been dragging out for several years, and we're hoping the money will start to flow in the second quarter of fiscal year 2022. There's no guarantees of this, but what we do know is that ultimately whatever amount of money does come into the state, a law was passed so that 70% will be funneled into the counties, and then 30% will come through the Department of Health Services, and there will be requirements for how that money is spent. I would recommend, if you want to get involved, it's important to start working with your county leaders, your county executives, because decisions are going to have to be made in each county as to how these funds will be used, and they cannot be used to fill potholes. So do not let anybody tell you that they can. So data collection and surveillance, prevention, harm reduction, treatment, and recovery. I got your back. We are going to fund treatment and recovery. And so hopefully we're going to start to see this money flow into Wisconsin very soon. So I know that this doesn't just mean me, but it was just at the end of my slides. But my email address was at the beginning. Seriously, please contact me if you have questions. And one thing I didn't have the slide up for, but Your Choice to Live is an organization that is near and dear to Renee's and my heart. And their presentations are phenomenal. They come into schools, they talk with teachers and parents and students. If that's something that you want to see in your community, please look into that because they do an amazing job. Thank you.
All right, we have about 20 minutes left here, but I did want to give our panelists an opportunity to, as I saw you jotting some notes down, if you would like to comment on something you heard someone else say. You've done it a little bit, but if you went first, you were at a disadvantage to commenting on anyone else. So if you want to do that quick here for a few minutes before I ask a few questions and then kind of open it up to some audience questions.
I just wanted to go back to the Narcan issue with what happens if they're like speedballing. So if they're mixing like cocaine with heroin, or the gabapentin or the Xanax, which is a very popular combination, would Narcan still be effective?
Yes.
Okay.
One thing I will add, though, is that what we are seeing with the fentanyl overdoses is that it often takes 2 to 3 to 4 doses of Narcan, which is really important for people to understand, and why we want, for example, law enforcement to be carrying several doses, because one dose isn't going to cut it.
And then my second question, I apologize. My second question, when you had said, first of all, sorry about your loss. Again, just really sorry about that, and as to why we need to continue working, because the codependency is as bad as the dependency. So the $40,000 the aunt invested in his addiction.
Yep.
A lot of people out here are doing that, not really knowing how bad that is.
Right.
Because of guilt or shame or whatever is going on. But the other thing that I wanted to cover was, God, I'm having a moment. So I find it very ironic, and I've been looking at this closely, maybe you have the numbers, Danielle, is that I knew a couple of people, or knew people who all died around the same time last year in March from fentanyl. And I've been looking at that like, wow. Around the same exact time.
So we've been working, one of the big voids of our data is there's a program that came out of Baltimore called ODMAP, and we have really poor overdose data right now. It's something I've been working on for a while, because ODMAP is an app that we would like for law enforcement and first responders to have, so that they can enter when they respond to a scene in an overdose. And we can put out alerts. So if there's an overdose that's, 5 in a 1 mile radius, and there's certain signs that they are seeing that these are connected, we can put out spike alerts, because it's important for people in the community to know, okay, I just bought heroin, it may be laced with fentanyl. These individuals, it could have been the same person. I am pushing for that like nobody's business, because we need people to understand what's out there and what they're taking, and the fact that fentanyl is being cut into a lot of drugs right now.
I just wanted to add on, overdose being the best high goes back to kind of what I was talking about with the dopamine and the glutamate in the brain, especially the dopamine. What happens is our threshold to feel pleasurable experience changes. And so we term that chasing the high. And so the first time you use any substance, and you can think if you've ever drank alcohol, the very first time you drank alcohol, you had nothing to compare it to, and you felt a certain way. And maybe the next time you drank the same amount of alcohol, and you're like, well, I didn't really feel it the same amount. Well, that's because you need to drink more for it to feel more pleasurable. And so what we see with substances is that you have to use more of that substance to get that high. And for a lot of substances, you reach kind of your max with that substance, and you may go on to another substance, and you'll have to increase the dosage of what you're using. And so when somebody overdoses, they've reached the max that their body can maintain, and that's the best high because it's the most pleasure they've ever felt. Or it's laced with something like fentanyl that they've never experienced before, and that contributed to the overdose as well. And so, it very much goes back into what's happening in the brain, the changes that are happening in the brain that we're very much not aware of. The other thing that I wanted to comment on is the kind of codependency, and what happens with that too is that, as family members, and I've been in a position of trying to support a family member with an opioid use disorder, we're trying to give them what they're telling us we need, and in our brains, the not drug use brain says, oh yeah, you need food, yeah, you need diapers, you need basic self-care, absolutely, how could I not give you that money? And those things are all true, but the person who's using substance use, those needs come secondary to drug as a result of their use. And so we have this basic we term it eat, kill, and have sex. So basically, nourish ourselves, keep ourselves alive, kill, protect ourselves, self-preservation, sex, procreate, nurture. Those are the basic things we're looking at being most important to us. When substance use is introduced and it gets to the level of a disorder, drug abuse comes above those. Now the person knows that those things are important and will tell you those things are what they need, and those things are what they need, but then when it comes down to using whatever you give them, it's going to go towards the drug because that's the #1 priority of the brain.
One example I wanted to give too about the comment I made about when white people are, addicted to drugs and kind of the privilege part. I was a community intervention specialist for 5 years for Milwaukee County Housing Division, and there had come a time from a group in West Allis where part of the privilege that I commonly think of is being told by a white male that they would rather sleep under a bridge than go to a shelter on the north side. And that just kind of took me back, considering, the work that I did and how that kind of was like a kind of a hurtful thing. Because I'm like, considering all that you've been through in your addiction, and for you to kind of discriminate help based on the attitude that the north side is dangerous, the same side of town you probably buy some of your drugs on, that was my thinking, I'm being honest, that you would say that you would rather sleep under a bridge than get help from a black person or even stay in a shelter on the north side. So that's just one of many examples that I've had providing services to people. And I've seen a lot of different things that over the years, I could probably write a book about my experiences being a black professional, working in the field, of the differences in, apples and oranges as it comes to race relationships.
I do have one question, and I don't know if you'll know the answer to this. Do they have programs for inmates to go into once they're released from jail. So after they're incarcerated, once they're released, if they had a substance use disorder when they entered, because Blake was like, it was like a week after he got out of jail that this happened. Do they have programs for that? I mean, are they supposed to be? I didn't talk to him enough to know if there was something like that out there, just because it was so quick after he got out. But there are programs like that for them to utilize?
Definitely. So to her answer is yes.
Okay.
But again, like with treatment and what they call recovery houses, it's supply and demand. And so when the demand exceeds the supply, that's what makes it difficult, right? And so, you know, and then plus I would add, just from my experience working in residential placements and halfway houses, that a lot of times, as good as it may appear to have like a transitional housing or something like that, if they're coming out of jail or prison, they don't want the structure or the rules. So that's what the problem is. Like, I don't want nobody telling me I can't come in at 10, or I don't want nobody telling me my girlfriend can't visit, or, you know, so that usually is the barrier.
Okay, thank you.
And I can speak to, you know, again, my work with people that were immediately released, if they didn't necessarily qualify for a sober living house or residential transitional, you know, they would get connected with their probation officer, their DOC agent, and they would quickly get them connected with us. It was either, you know, by their self-report or their drug testing them, they test positive, they get sent to us to at least get connected immediately. Unfortunately, I don't know what kind of treatment is being provided at this time since our contract ended in 2019. I'm not sure where things went with that. There was a program that picked it up, but then the pandemic happened. And then my understanding is some things fell through the cracks because it's really hard to provide a group therapy in a virtual world, especially at the beginning of the virtual world. And so I'm not sure where it is right now, but that was kind of one of the bridges that we were trying to make too with that contract of people being released and they need to stay sober. And even if they don't identify that they have a substance use problem, they're testing positive, that's a problem. Getting them connected to us helping them process through of, you do have a problem on some level, let's keep getting you help and try to get you connected with whatever resources we can.
And I want to add another thing, and I know we can talk a lot about this. I'm sorry, we can talk a lot. So another barrier is a lot of residential programs and recovery houses do not accept Suboxone and methadone and other kind of.
And he was on those.
Yeah,
as
and they
well,
don't, so you have to now decide, do I want to be in a recovery home or do I still continue my medication assisted treatment? And so that's another barrier that a lot of times people don't think about. And so those are some very like life-provoking decisions. Like, wow, what am I going to do, you know, in order to keep my sobriety?
And even some of those treatment, medication assistant treatment programs have their pitfalls too that make it really hard for people to want to continue to engage in them. Like showing up every morning at 6 a.m. to get your meds every day. And if you don't, then you don't get one. And then it's just that, you know, there's a lot of barriers there for people, you know, at least getting connected and started on the right track. Or finding a doctor who can do some, you know, like a Vivitrol shot, which is ideally the way we want to go, because there's no high that's coming from that, but there's not enough providers, insurance issues. I mean, all the things we find with any kind of treatment is a barrier that we see.
Yeah.
I just wanted to piggyback on that. At the Department of Justice, we work on TAD, or Treatment Alternatives and Diversion, and we've been putting out a lot of grant programs related to medically assisted treatment for individuals who are being released, and also releasing people with Narcan, because we know that if you lose your tolerance, and people who are released, this happens a lot, unfortunately. You've been in custody for a period of time, you weren't using, you get out, the first thing you want to do is get high, and that ends up very often being fatal. And so we are working to make sure people are released with Narcan, working with Department of Corrections, because the concern is, well, I can't take the Narcan because then my agent's gonna think I'm using, and if they think I'm using, then I might get revoked. And so we're coming a long way with this, and really trying to, working with the Badger Sheriff's Association, for example, to say, okay, here's all the Narcan, and you're going to release this person with Narcan because that is our best chance at saving their life.
Can we maybe move to some audience questions if we have any for now? Okay, I see a couple hands here. I know you guys could continue, but I promised.
Thank you. I've learned so much. Thank you. I was a hospice nurse, and the escalation of the opioid in the mainstream paper came out as I had left. So if I'm thinking correctly, when you speak about the escalation, we would call that tolerance.
Yes.
If that's still true, then I would hate for us to leave here, because we've had families withhold medication from dying patients because they were afraid they would get addicted. So I wonder if you could address that, because that was a problem. We would use fentanyl patches because then they wouldn't have to give them the medication. We could change the patch. And I haven't spoken with anybody in hospice for a while. I'm not sure what they're doing, but I just would hate for anyone to withhold medication from a dying patient because they're afraid their family member will get addicted.
Yeah, and it's my understanding that, as we've made all these changes with the opioid epidemic and trying to figure out who should get medications, who shouldn't, that it's really trying to reserve medications for those people with terminal illnesses, and if they're dying, to let them die in peace. Them being addicted, is that going to matter? We're talking about quality of life. And at that point, you're talking quality of life and as minimal pain as possible. So yes, can certainly understand the concern, and also, concern that a medication like morphine might actually be the reason why a family member is killed. And trying to understand that we are talking about quality of life and minimal pain, and sometimes you have to weigh that more in terms of the tolerance, because when we talk about tolerance, it's the long-term effect of tolerance. And the reality is this person doesn't have that long-term of a life.
You spoke about using correct language. I used to say that, I used to tell my students, tense your body up like you have pain. And so I would say, tense your body up. And how can you die if you're tense? So instead of saying morphine kills, morphine allows the body to relax so that the natural dying process can take place. Because if we say it kills, the family's going to really freak out and not want to give that dose of morphine. So again, the language is important.
Yeah, absolutely, and trying to convince family members who have a belief system that is inaccurate. But yeah, progressive muscle relaxation is what you're talking about. It's one of our best coping skills for relaxing the body and keeping it in a more relaxed state.
Can I just add something to that? Because that's definitely, so I've been working with home care and hospice, and that's absolutely what we're still seeing, is that some of these things apply, but absolutely not to someone at the end of their life. So I'm definitely not seeing that. I absolutely understand your concern. One thing that I do see from the diversion and drug take-back side of thing is that our current state law is that if there are the medications of someone who has passed, is the property of the estate, which to me is very, very interesting and something that I've been working on looking at, because you leave behind all of these medications for the person who has passed. Those medications shouldn't stay, morphine, all of these very strong medications shouldn't then be in the house for the family member. So they can say to the hospice employee, you can take this, you can dispose of this, or they could say, we're going to hold on to it, which we see a lot of diversion, and we've seen, unfortunately, suicides. And so that's something I really want to see us continue to work on, because if they fall into the hands of the family member that those medications were not meant for, you're going to see consequences to that are, unfortunately lethal.
My auntie died at home, and she had pancreatic cancer. And the responsibility of the provider was to bring it a locked box with the medications and just not leave them there. And so that was kind of one of the things that needs to be back in practice. And I think they also do that at the methadone clinics. Like when you take methadone home, you have to have a locked box for it. You have to sign a contract, like where it's going to be at. if there's any children around and things of that nature. And then keep in mind that I don't know where and when doctors started prescribing these high lethal doses of medications to regular injuries, but the opioids were really designed to be for cancer and like very harsh type of illnesses or death type things, not just toothaches. So I think that, not to blame, but there was an irresponsibility on the part of the medical profession to give these type of medications to things that were mostly applicable for after surgery and things of that nature.
Do we have another question? Maybe have time for one or two more.
Can you speak to the legislation that was just signed by Governor Evers with the fentanyl test strips and the good hope we have that that will be something that's going to be extremely helpful?
Yes, I was going to bring that up, so thank you. I just received a pen. Every once in a while, I get those pens when a governor signs a bill into law, and so I received a pen because I worked on that legislation because the legal opinion was that fentanyl test strips were considered drug paraphernalia under the law, and so we had to get that fixed PDQ, and fortunately, we got that through the legislation or the legislature, and the governor also on the same day signed a bill to make the possession and distribution penalties for fentanyl mirror the heroin bill, because we saw that this was a trend, this was a very deadly drug, and we didn't have laws that would give prosecutors really the tools to use it. So the governor signed that bill on the same day. And I have a friend who lost a son to a fentanyl overdose last summer, and I got a pen for her to give it to her to say, and this is why I do what I do, because every time I hear a story like yours, it hurts my heart, and I have to believe that what we're doing every day is gonna not have another mother feel this pain. So
That's my hope too.
All right, we'll maybe take one more question from the audience if there is one. Right up here, Renee, up in the middle. Yeah.
So I'm thinking, Jennifer, maybe you use this term, I'm not sure, or maybe I misunderstood you. Did you use this term disease of choice? Okay, so my daughter and I had a very, I'll say, heated discussion about choice in addiction, and I have some personal experience with this, as does she. When does it, philosophically, when does it stop being a choice and when does it start being an addiction? Or I really struggle with that, because if it's a choice, then someone could choose to deal with their substance abuse issue. If it's not a choice, if it's a disease, then I guess you don't have a choice. So I really struggle with that, so I'm curious what you think.
So the phrase disease of choice, it was our attempt at explaining, for a long time people felt that this was just a choice. It was a personality characteristic, it was a flaw, and it was the person's problem. It was their choice, they made that choice, they had to deal with it, they were refusing to do anything about it. Other camps were, no, it's absolutely a disease. I fell, as many did, into the disease of choice, in that sometimes you make the choice to use it the first time, maybe even the second time, maybe even the third time. But at some point, the choice becomes less of a choice and more of a disease. And the way that we know that that happens is that cravings to use, we've all had cravings. Tell me you haven't craved a certain type of food. Tell me on a stressful day you haven't thought to yourself, oh man, I could have a glass of wine. Those are cravings. They're very natural. They're things that we have, but they're not our conscious thought. And so cravings within substance use, it's not a choice that we make to have. It's the result of the dopamine and the glutamate, specifically the glutamate saying, oh, this is really important to you. I'll help you remember this in times of crisis or high stress or high emotion, that this is the thing that you need, and I'll make you think about it. And so it becomes a disease when cravings start to play a role and what they're experiencing, because we don't choose cravings. None of us choose cravings. It is something that pops into our head, whether we know it or not. It's an automatic thought. And so at what point, it varies from person to person. One person can use a substance and another year later use a substance and choose to use it again and never have it develop into anything else. Another person can use it, could use it a month later, and never have it develop into anything else. Another person could use it a year later, and then start using it every month, and then it become a disease. It's an art, not a science, as to who and when it develops into being more than a choice. And if a person is struggling with using a substance quite frequently, then, seeking individual therapy to help them explore, is this a disease that you're dealing with, or are you continuing to make choices, or is, what's going on?
I think to add to that is the one thing that makes opioids or heroin and stuff different is the physiological part of it. You get dope sick. And so if it only takes a bump to get you from being dope sick, like having the flu, then that is what causes the cycle of the disease of addiction. Because unlike other stuff that's out here, that's why, like, when she was saying about the methadone clinic, the methadone clinic serves between 5 in the morning to like 1 o'clock in the afternoon. So everybody has to go get their methadone first thing every day in the morning. Because when you become dope sick, that's what causes the going out there and not doing nothing else but trying to seek that drug. And so they get really, really sick, and that's what causes. So if you can get something that really quickly takes all that away, that's what causes that to keep manifesting itself.
And each substance has withdrawal. I mean, we see withdrawal with all substances, but we're talking about with opioids and alcohol, it's a potential life-threatening withdrawal. Whereas
Yeah, alcohol.
opioids,
Yeah.
correct, if you take care of yourself, you're correct. Well, you do have to hydrate yourself, and you do have to get rest, and if you don't do those things, then your body is at risk of shutting down. It's not as life-threatening as alcohol. We believe it feels that it is, and yes, you're right, we can manage it at home. We can do things to ride it out at home, absolutely. It's not as life-threatening as people think that it is, but if you don't take care of yourself or you go and you use again, then it becomes life-threatening.
All right, we have reached 8 o'clock. Thank you guys so much for your time, for being here. It was so helpful. Please give them a huge round of applause.
What a terrific presentation. We thank you, Terri Ellzey, Danielle Long, Jennifer Smith, and Beth Ritter, for your time and wisdom. Please, let's give this impressive panel another round of applause. Special thanks to our event sponsor for this informative program, Rogers Behavioral Health. And thank you to Impact members, Allison Wolf, Events Director, Carla Cummings, Programming Director, Jill Boyle, Beyond the Headlines Chair, Renee Mannion, Programming and Outreach Chair, and the many volunteers that helped make this evening possible. Great work. At the heart of Impact 100, Greater Milwaukee, is the belief that through our collective giving, we can dramatically improve our community with transformational impact. We are utilizing the power of smart, very talented, and passionate women. Your generous donation helps to provide significant and transformative $100,000 grants to our nonprofit recipients in the Greater Milwaukee area, and also helps to enable us to provide great programming like this evening. One woman, one gift, one vote. We know we are stronger together. We hope to see you June 8th at the Pfister Hotel for our annual awards celebration. It is such an inspiring evening. We will be awarding $405,000 in grants this evening. Watch for an email invitation this week. Thank you and have a great evening.
And don't forget to visit the food table. There's a lot of food left. Thank you.